Well, hello and good evening from the Institute of Healthcare Management. Welcome to this evening's Health Chat, where we have a blockbuster evening in store for you. I'm delighted to be able to introduce Mark Britnell, who is the Global Chair for Healthcare, Government and Infrastructure at KPMG International. And of course, taking him through his lines is the fabulous Roy Lilly. And he needs no further introduction, I don't think. So all I'm going to say is these are becoming extremely popular within the IHM. We're so thrilled you're all joining us this evening, and do keep a lookout for more to come. I'm going to hand on to the two stars of the show this evening, and I'll be back to facilitate question and answer at the end. So for now, Mark and Roy, the stage is yours.
Wow, thank you very much. Thank you, John. We look forward to hearing from you at the end with all the questions. So if you've got questions, whack them in, and then Mark will be pleased to answer them. And if he can't answer them, then I'll make up some answers. Mark, how are you doing? This is the only time I've ever known you to be in the UK for longer than about 10 minutes. You got cabin fever.
Well, I'm really pleased, actually. It's the first time in 11 years I've spent more than 3 consecutive weeks in the UK. So although, of course, this pandemic is terrible, I'm catching up with my kids. I'm speaking to you now from my kitchen. I'm cycling every morning, doing my work on Teams. So I'm pleased not to be flying, actually, Roy. I did 9 countries in the first 2 months of this year. So I'm happy to be in the UK.
Yeah. And
I'm delighted to be speaking to you and John today as well.
Well, it's great to see you. I mean, on the question of flying, I mean, I'm kind of nervous about the whole prospect of flying in the future. You know, I used to get on a plane, never think twice about it. But now, you know, I'm not so sure. I'm not so sure I want to get on the tube either.
Yeah. Well, I mean, I obviously fly a lot. The average is about 35 countries a year. But I've come to realize 2 things over the last 10 weeks. First of all, I'll never go back to my old way of flying, partly because my daughter's 15 and quite rightly she gives me a lot of grief about carbon emissions, and that's right and proper. But also I think, and we're noticing this across the world with KPMG, I think the aviation industry and other industries related to travel, sadly, are going to be one of the permanent features of scarring through this I call it now depression. I think it's a recession at the moment, because I know even big companies like ours, we've got 225,000 people around the world. We operate in 157 countries. I was on a town hall meeting last week, which had over 2,000 KPMG staff from 57 different countries and God knows how many time zones. And it worked really well. And the benefit of it, of course, is that people who don't naturally feel confident to speak or ask a question can simply type a question in and have that question answered. And if the answer isn't satisfactory, instead of just keeping quiet, they politely say, "Can you expand?" which means stop waffling, give me the answer.
Give me a better answer. Yeah, I like that. It is interesting. I mean, but there's a lot for us to get through, but it's just interesting to get your take, because I was pushing very early on when all this started to get the NHS to start working from home. They had real problems with that because they didn't have enough licenses. That was the first thing. Yeah. Secondly, they didn't have enough bandwidth in order for people to talk to it. I think most places have kind of fixed that now. And it does have, I mean, you used to run a hospital, you know what I'm going to say. I mean, this is going to have a big impact on the size of the NHS estate, capital charges, and actually the prospect for development, because I'm sure we've got quite a lot of backroom offices that actually we could turn into patient-facing, money-earning value in the NHS.
Well, there are 3 things that strike me on that. First of all, when you look outside health, as we have to at KPMG, the first thing that happened in China, or the second thing that happened as the pandemic spread, is that businesses stopped paying rent. The second thing that happened was that businesses then started to renegotiate rent. And the third thing now that we're seeing, I'll come to healthcare in a moment, is that most companies now obviously have to worry about their cash flow to support their staff and serve their customers, are radically rethinking the size of their footprint, which actually also has an impact on carbon emissions. In healthcare, my estimate is at the moment that about as far as anyone can tell, 3/4 of all face-to-face consultations, primary care or outpatients, have been switched to virtual consultations. I think the latest figure in the UK is 82% of all primary care consultations. As you know, I don't want to take you back to Henry VIII and the abolition of the monasteries, but actually 20th century hospitals, 21st century hospitals can trace their lineage back to the abolition of the monasteries. And they were all built around rich doctors not wanting to walk anywhere and letting the poor come to them. That's how outpatients departments were created. So if you want to be very historic about this, this is a 500 to 600 year reckoning that we're seeing being played out in 10 to 12 weeks.
Yeah, it's just interesting. I was saying the other day that, you know, I've been around the NHS for a long time, and I've seen more innovation in technology in the last 3 months than I've seen in the last 30 years.
Yeah.
And I mean, what's your view? Is it stickable? Do you think it'll stick, or do you just kind of slide back? We've got to change. We've got to change the way we the contracting. I mean, hospitals get, what is it, 250, 300 quid for a standard outpatient appointment. If you do that online, they're not going to get that cash. And because outpatients is a big cash cow for hospitals.
So I think the answer to your question is definitely yes. So when we work in countries, say like Australia, they have a phrase, no return, no regrets. So many countries now are planning to use, obviously, digital. Where it's been tried in pockets in the United States before the COVID-19 crisis, the way that you have to do it is to be supportive. So you have to taper the investment out of face-to-face and ramp the investment up into digital, because most organizations know it makes sense. They worry about their revenues. Therefore, you have to take the anxiety out of that and give them a period of time to manage through that. In parts of New York where we've worked, New York State, it's taken 3 years. My view now, it's going to take about a year or so. Because people are familiar with it. On Friday afternoon this week, I was talking to the healthcare team in Microsoft. They're about to make a big announcement on Tuesday because they've seen that their Microsoft team is being used for healthcare staff and also staff to patient consultations. They're a very big organization, as you know. They're now really investing heavily in reorganizing their suite of products, which are cloud-based. So I think the answer is yes, and also because, rightly or wrongly, staff in the NHS or staff in healthcare have always been, I think, have questioned the reliability of the technology, not the power of the technology. And I think increasingly now, whether it's Teams or Zoom or whatever, I think people have got more confidence in it. I should also say that I went to Kaiser Permanente in Oakland last June, and I wanted to lift the bonnet of Kaiser to see whether the rhetoric matched the reality. And even then, they were doing 78% of all their consultations remotely. And I spoke to the patients, but I also spoke to the clinical staff. And the clinical staff said, we won't go back for 2 reasons. One, we couldn't see all the patients. And secondly, we quite like working from home 1 or 2 sessions a week in our pajamas or our tracksuits, and they get more productivity out of us. When you ask the patients, quite simply, if you've been to Oakland, it's quite an expensive part of San Francisco, California. The patient said, I'm not going to pay $7, $10 an hour to park my car, to take my 2 children for a 5-minute chat with a doctor. If I can do that and it's 7 minutes on the phone, everyone's a winner. So I think, yes, I do think it's here to stay.
Yeah, well, I'm pleased that the Academy of Fabulous Stuff, you know, we run. We've got a campaign going on at the moment called No Going Back. The ideas are just flooding in with people saying we want to do this forever. Okay, right, let's go back in time, Mark. Let's go back to December last year, when the reports of an unknown pneumonia that suddenly started to emerge. It became, of course, COVID-19. We didn't know what it was then. I mean, people think it's been rattling around a bit before then. And China sort of told the World Health Organization, apparently reluctantly, that they had a problem. And we went from there. Do you think, this kind of gets us really into, I'd like to get into some comparisons between country to country to see how they got on, but I'd like to start by looking at it from the helicopter point of view globally. And I'm wondering really, if our response, it's been very piecemeal, country by country, how we're dealing with it country by country. If we reflect on for example, the world financial crisis, there were, Gordon Brown, got off his backside, and give him his due. He traveled around the world and tried to sort out a solution. We've not had any global approach to this, have we? And given that, healthcare is such an important thing. I mean, I'm not saying the economy isn't important, but you know what I mean. Why do you think it is that we've not had a global response to this? Is it leadership, unwillingness? How do you read that?
It's a great question, Roy. So I was working, as you know, for government in 2009. I think perhaps Gordon Brown was underrated in the response that he managed to galvanise in the global community. But I've been spending some time thinking about this. So, of course, now in 2009, after the great crash, we then had a huge number of regulatory financial stress tests. I hope that we start to stress test healthcare, because at the moment, and there are three quick remarks I'd make to your question. The simple answer is that governments respect money more than they do people. That's changing now very quickly. The second issue is that institutions have been built up globally for finance over decades. Think of the World Bank. And thirdly, I'm sorry to say that the institutions that should have been coordinating, whether it's the World Health Organization, the United Nations, G7 or G20, there has been no response whatsoever. And as you've seen, sadly, between the contretemps between the United States and China, it's not bringing out global cooperation, it's bringing out ugly nationalism.
Yeah.
Whether it's criticizing China or stopping international comparisons and saying they're of no benefit, this is not, I think, a progressive way to solve this problem. We know that every health system is not an island. No country is an island, and this virus respects no national borders. This pandemic has not got a passport. So I think when we come to reflect on this after the first wave, hopefully before the second wave, that there has to be much more global cooperation. The European Union has let basically each country fend for itself. And my simple answer to your question is, historically, governments have valued finance more than people. And now, two things I see. I've got many observations. I wish we had 2 hours this evening. But essentially, the book that I wrote, the second book on solving the global workforce crisis, I now know that every country in the world has got that message. Just think of the UK. Our economy is £2.75 trillion. We've got 100,000 vacancies. Of course, staff have been heroic. But if occupancy levels were 80%, not 90%, if most countries had decent staffing, that would have acted as a great insurance policy to restart economies sooner rather than later. Now, even if governments don't care about people, and I hope they do now, they care about the...
Oh, we've frozen Mark.
Economy.
Oh, sorry, Mark, you just froze for we've frozen you again. Let's see if we can get back to Mark.
So that's the first point.
Right, you've just frozen on us, Mark. Can you just recap the end of your last observation, please?
Of course, my apologies for that. In a nutshell, I think governments have realised now that a well-staffed, well-funded health system, in comparison to their economic wealth of their country, is small, and therefore investments in health now should be seen as cost or sinkholes. They should be as sensible investments in national insurance and economic prosperity.
Well, we've certainly seen that, but I mean, amazingly, in Parliament today, they're debating an immigration bill that's going to put the price of the cost of overseas health staff coming here up to 600 quid. If you add to that, a few thousand quid on for each family, and the fees to use the NHS and regulatory costs and all the rest of it, it's bloody expensive for overseas staff to come here. And as you said in your excellent book, Human, we're in a global marketplace for staff. They don't have to come here.
Yeah, well, what I think this pandemic has shown is whether you're a healthcare assistant or a professor of critical care, you're both equally important. The second thing I think is that we should reserve our temptation to point out to governments that have pursued smaller national policies, because we know in care services throughout Europe and the world, they are badly paid and understaffed.
Yeah.
I think now every government, when you listen to its rhetoric, it will not be able to escape the reality after this crisis of making sure that aged care services, social care services are put on a sound and sustainable footing.
Well, I hope so. I mean, certainly our care homes aren't. Let's have a look around the world then, Mark. I mean, pretty early on, Germany was held up as something of an exemplar of how we do it. They were fortunate in that they had a residual testing capacity that most countries didn't have. It wasn't just us. Most countries didn't have. They came through it with a pretty low level, I think, of infections. Although their care homes, actually, they had a problem in their care homes, just like everybody else had a problem in their care homes. Then I think Mrs. Merkel rather reluctantly succumbed to pressure from the 16 federated states in Germany. She said, okay, if you want to open up, sort of on your own head, be it. Now the R number, which is a bit of a con, I think. It's just an average and it arrives 3 weeks late, but it's all we've got. The R number is going up and it looks like they might have to clamp down again. I don't know, is it right to say they handle it well from the off? I think they might have done.
Well, another global observation that I've made is where countries had more confidence in their health service to effectively tackle the virus early on, their strategies were more aggressive. And some countries like ours, when you think about the slogan about saving the NHS or protecting the NHS, we defaulted to drawing our horns in to make sure we could protect critical care capacity. And that was because of the images from Lombardy in Italy. But if you think, before I come to Germany and aged care, about Taiwan, Singapore, South Korea, they all obviously have decent health services. They understood that they had the good healthcare to fall back on, but instead of retreating from flattening the curve, they advanced to crunch it. So we've all seen now the stories from South Korea or Singapore about their test, trace, track, treat capabilities. In Singapore, of course, the juxtaposition of CCTV, credit cards, GPS tracking technology. We're still talking about whether we're going to use our app or not. So the first thing I would say is, actually, as a global observation, some countries had more confidence in the resilience of their healthcare system and therefore attacked the virus head on in terms of contact tracing and all the other things we've seen. Now, in terms of Germany, of course, we know that they fund their health service better. They have more critical care beds. Their occupancy levels are less than 80%. So I think what happened in Germany, speaking to my colleagues in Germany, they felt quite sure that their health system would be more resilient than the Italians. And of course, they then had public-private partnerships to expand testing very quickly. And we saw the early results of that. And they were impressive, very impressive, when you look at Spain, France, Italy, and the United Kingdom. Of course, what's happened now, they've been one of the first European countries to ease restrictions. The Bundesliga played, I believe, yesterday for the first time, which is always a sign of confidence. So I think you'd expect the rate to rise. But yes, you're right. When you look at the global figures, Roy, as far as we can tell, about 50% of all COVID deaths in Europe are taking place in care homes. And between 10 and 20% of COVID deaths in Asia, say South Korea and Singapore, are taking place in care homes. So I think there was a big issue. Now, we can argue whether Europe has a slightly older population in terms of its demographics, although in South Korea and Singapore, they're also aging quite rapidly. Hong Kong as well, no reported deaths in their care homes. Find that a bit difficult to believe, but even if it's not 0%, it's not going to be 50%.
Exactly. Yeah.
And what they've done is, and this is, of course, I know you've been writing about this, and you've been commentating on the fragility of the care home sector in the UK sadly for probably decades, if not years, and people might find this surprising, but in Singapore and in South Korea, every staff member is tested every shift. Every patient coming from a hospital is tested, otherwise they're not brought into their care home. They have dedicated rest facilities and accommodation for their staff. They treat them with the respect they deserve, and they get the results, therefore, that their society deserves and demands.
That's an amazing thing, Mark. It really is a huge difference. I was just actually going to ask you to say a word about France, because again, I mean, we can't compare any of the funding, because we've had 10 years of flatline funding and fallen way back. I mean, I think we were on the European average, but we're way behind that now. And even if with more money, we're still going to catch up. But France has been a bit like Germany. It's invested consistently in its care homes, in its healthcare system, but it was still sideswiped by this, wasn't it? It didn't do really any better.
Yeah, well, anyone that knows the French system knows that although there is regionalisation to it, there is great fragmentation within the system. As you know, it's got public funding, it's got charitable funding, it's got religious funding, and it's got for-profit private funding. And once you get out of the health system, you've then got the same issues that we faced in aged care. So I think one of my observations, of course, is that systems that believe in social solidarity, whether it's a beverage type system that we have in the NHS, like Spain or Italy, or a Bismarckian system with social insurance like they have in Singapore or South Korea, they have done better than systems that haven't got universal healthcare. Look at the United States, look at Brazil. But then when you look at other countries that seem to be doing better, they're smaller, the Scandinavian countries, they put aside the regionalisation of their health system and had much more central control. Now you can do that for populations of 5 to 10 million, whether you can do it for a population of 60 million in the UK, 55, 60 million in France, 80 million in Germany, it becomes much more difficult. And of course, as we've seen now in the States, once that line between federal and state government becomes politicized, as it is now in Brazil, by the way, in Sao Paulo is under siege, really politicians are putting politics before people. And I just hope that people remember that when it comes to the next electoral cycle. So I think on the French issue, better healthcare, yes, but more fragmented when you get inside it. And then the handoffs to aged care and social care, also not that seamless either, Roy.
Yes, and that's a really interesting point, because I was thinking about writing a piece, perhaps next week, about there's one bit that's missing in our system, and it's the regions. Because if you remember the regional health authorities, they were big enough to matter and get stuff done, but small enough to attenuate to what was happening, to figure out what was happening. And it seems to me that particularly on as we ease our way out of lockdown, we are missing a regional structure that can boss some of that. And just again back to France. You look at France, how they're easing their way out. They've got a big slab of France that's green with one set of rules, and then all the arrondissements in Paris and in the sort of centre, they're all red, and they've got a different set of rules. And I was just thinking, we do miss that kind of regionalness, don't we? I mean, I suppose you could say that Germany's got that regionalness in the federations. But there again, if you look at what's happened in the States, who got sort of regionalness in the federation, they're in a huge mess.
Yeah. Well, I mean,
I suppose, sorry, it's a rather long-winded observation, Mark, but I mean, what I'm getting to is, do the structures matter?
Yes. I mean, I don't want to plug my books, but the first one, In Search of the Perfect...
Why not?
Well, no, just to say en passant, in the first book, In Search of the Perfect Health System, in one of my chapters, I said that the ideal population size to transform health services and to still have a clear line of sight to the patients and managers managing locally is about 5 to 7 million people. And I said, look at Singapore, look at Hong Kong, look at the Nordic countries, for example.
Yes, and look at Hong Kong now.
Yeah, and I was a chief executive of one of the strategic health authorities. And so I can see the arguments from Andy Street in the West Midlands, from Andy Burnham, of course, in Greater Manchester, that those arguments, for me, make a great deal of sense. However, they only make sense if your technology and digital prowess is on the money. So if you look at China, which has obviously very big regions, and Taiwan, which has taken a more centralized approach, it doesn't matter because, as you know as well as I do, Roy, that if you've got technology which is personalized, it doesn't matter whether it's a street, a town, a city, a region, or a country. Because what we're seeing now in China and Taiwan is, you know, they've got the red, amber, green systems. You can travel anywhere if you've got your green stamp. You can't travel anywhere if you've got your amber and red. And so, of course, we're seeing now economic activity start to increase where you've got green zones. So this issue about tracing, tracking and testing is not just, of course, about tackling the coronavirus. It's about standing up the economy. So I hope that our applications work sooner rather than later in the United Kingdom. I know the four administrations now, Scotland, Wales, Northern Ireland and England may go their different directions, but the great unifier is tracing and tracking, testing and isolating to reopen schools and the economy. So we've got to get close and personal. We've got to.
Why, Mark, why are the Far Eastern countries that are doing it, why are they better at doing it? Is it because they had a sort of dry run with SARS and they learned a lesson?
Two things. You know, the Western world didn't suffer the 90s global financial crisis that hit Asia. So they're very concerned about financial crises. It plunged, you know, you've got a big middle class in Asia now. It's the engine of the world's economic growth in many respects, along with Africa. But they lost many middle class people into poverty. So they understand that their national welfare and the ability to raise taxes and pay for public services depends on a strong economy. And then, of course, as you said, SARS 2002-4, MERS around the same time, they didn't forget the playbook. They played the playbook, they rehearsed the playbook, and then they made sure as soon as that playbook needed to play, it was played quickly. Yeah. So issues about, debates about masks that we have in our country, no debate. Debates about closing borders, no debate. Debates about quarantine, no debate. Now, some of that's got to do with the political complexion of certain countries, like China. Others are fully blown democratic institutions, like South Korea. So yes, that they were alert and alive to it through SARS, but their playbook wasn't a dusty policy document.
No,
it was a question of life and death.
Yeah, I remember right at the start of this saying that years ago I'd done the Easingwold Civil Defence training course, 3 weeks at their college, and the playbook for that at that time is not a lot different to what happened here. And you know, it was pretty clear that a lot of the stuff that we were doing was correct, but it was too late or not. Yeah. What about other countries? Have France got an app? Of Germany, Spain, Italy?
Yeah, they've all got local ones. So the one that I've been working on, there's quite a cool care home app now in Italy. They're also using it in homes, in people's homes, which is of course the safest place to help aged care if you can. The apps now track temperature, blood pressure, oxygen levels and pulse. It's all uploaded in real time. They've got a command center, which is, as you know, like an air traffic control center, monitoring this all the time. We've helped in Switzerland do the same with their cantons, which are much smaller, 26, I think, in Switzerland. So, and Italy, of course, like Spain and France and the UK, you know, there'll be a big political reckoning about aged care and social care. I mean, I don't like this phrase, Roy, but it's the first time I've heard in the 7 or 8, 9 weeks that Italy were referring to some of their care homes as the killing fields. And that is, I mean, it upsets me to say it, but it is a very strong emotion. It conjures a very strong emotional image. Yeah. Yeah. So I do think, you know, lots of systems, lots of countries in the world really have been caught short by the aged care debate.
Okay, look, John's put a little message in my ear that we're up against the buffers of time. I'm going to ask you the tough question. This is the $64,000, $10 million, whatever it is, question mark. Who's handled it the best? Which country?
For its size, either Taiwan or South Korea. But if you want less developed countries that have done very well, if you look at what's happened in Vietnam and Costa Rica, where they've gone back to classic traditional contact tracing with human beings and bits of paper, Vietnam and Costa Rica have done very well. But I would say is full-blown democracies, Taiwan and South Korea.
Yeah, really interesting. It's the forest again. Right, Mark, we got, John, have we got some questions? John, speak to me. Have we got some questions?
Yes, we have. Yeah, we've got loads actually. So I'm going to, if you could just limit our answers to as pithy as we possibly can.
Well, I'm going to go down the pub and leave Mark to it, except I can't go down the pub.
Can't go down the pub, Roy.
First one, and this is kind of 3 questions into one. Will COVID lead to a wholesale redesign of clinical service delivery in the UK? And will it change the rhetoric that we use when we're describing lessons observed rather than learned?
Do you want a short answer, John? The answer
Please.
is no, it won't completely transform it, but it will transform it enough. If I had time today, there are 10 things that I see. Dirty, clean, hot and cold, centralisation of specialist services, scale in primary care, digital technology in aged care, supply chain resilience, the introduction of new control towers and command centres, and new region-wide forms of governance, because no country is tackling this on a hospital-by-hospital basis. It's all being done pan-institutional. So some of the work I'm seeing now from the ICSs or the regions in the UK, in the NHS in England, I think they're positive and promising. They won't deliver all that they promise, but they will start to change the way we think about change, especially because we've all seen clinicians in the driving seat in our countries, in the UK, in sorting out some of the issues that need to be sorted out. Clinicians need to keep that confidence. It shouldn't be crushed by regulation or too many bureaucratic tiers. And I really hope we keep hold of that spirit of can do.
Let's keep our fingers crossed, Mark. Okay, what's the next one, John?
Should experts lead pandemic responses rather than politicians? That is from Julie, who gives the example of Seattle as a case study.
It's a great question, and it's tempting to say that experts should run pandemics. I think, depending on where you are in the world, politicians now are either standing up or crouching down, because at the end of the day, these balances between the economy and people, between life and livelihoods, I still believe, as an old-fashioned Democrat, that politicians that we elect need to make those decisions, but people can't hide behind the science. And therefore, I think our scientists need to speak without fear or favour. And so I would say I still want my politicians to take decisions, but of course on the best available science. So I guess I'm trying to hedge the answer to that question.
Well, it is an interesting answer, Mark, because if you look at what's happened here, we get these dreary 5 o'clock press conferences, which suggest they're awful. And the scientists stand there and they talk, and we've seen now that they were wrong about masks. Why? Because we didn't have any masks. They were wrong about changing the guidance on PPE. Why? Because we didn't have enough PPE. They've been wrong about the placing reliance on the R0 number, which is really hocus pocus if you understand how it's compiled. I mean, I personally, I'm just, this is my personal view. I don't have the confidence that when I started out with this, that I had with the sort of army of scientists and chief this, that, and the other that are paraded at 5 o'clock every day. You know what? I don't listen anymore, because I think they have a conference in the afternoon before they go on. They decide what the line is, the science that will support it, and that's the political line. It's clear that they haven't been independent. I mean, you can just see it.
Yeah. I mean, I think I don't want to get drawn into that for obvious reasons, but I do think.
Sorry, Mark.
I do think the debate about, for example, SAGE making its methodologies publicly transparent.
Exactly.
Is really important because, I say again, no health system is an island. This pandemic does not have a passport.
Well, look at the Bank of England monetary, whatever it is. They tell us why they arrive at those decisions, and you can't have confidence. I've lost my confidence in them anyway, and I don't think I'm the only one. But I won't ask you to get yourself tangled up with me. Right, John. Let's get Mark out of jail. Give him another question.
Yeah, this is a UK-based question, really. there's two questions similarly. It's basically, what authority will ICSs have to reframe health and social care in the COVID aftermath in the UK? Should we get rid of the CCGs? Should we hasten the abolition of the Health and Social Care Act?
Great question, whoever I'll stick.
It's a combination of three, actually. There we are.
Well, as you know,
it's the composite.
We helped stand up the Nightingale facilities in the West Midlands, Yorkshire and London. And my observations, having come back into the country now for the last 10 weeks, ICSs are going at different speeds. So if you look at the letters coming from London, they're, all power to the ICSs. In other places where the regions are quite close to the ICSs, it's a different tempo. But on the question of the Health and Social Care Act of 2012, if it wasn't dead before, it's certainly dead after this pandemic. Because the best thing that we've seen is clinicians doing the right thing as quickly as possible for patients and for this country. And we owe them a great debt of honour and thanks, but also we need to learn the lessons of this and make sure that we move to a different way of managing as soon as possible after we've triumphed over this virus. So I don't think it could be any clearer in the answer there, John.
Thank you. No, I rather concur with that. I'm going to ask you a final question. This is more of a global question, international question, but I really like the nature of it. Will COVID change the nature of globalization in terms of workforce, public health, and the way that globally we look at transmission?
Well, perversely or paradoxically, I think there'll be two different trends which are contradictory. So I actually think there'll be a speeding up now of the globalization of the workforce as countries realize, whether it's fruit pickers or care workers working in nursing homes, they have value and they should be valued. So I actually think you'll see more of a global scramble for healthcare workers, because as I said before, every country realizes now that a strong health system is not a cost, it's an investment in our society and it preserves our economy. But I'm now seeing in double quick time, countries becoming less reliant on China for their global supply chain. And I've got lots of examples, but one that I like is in Vancouver, where they're already now thinking about regionally, and that's obviously a province in British Columbia, is a province in Canada. They're starting to look at domestic production now of sterilisation facilities, supplies, PPE. So I think when you look at the playbook of resilience for countries as they go through now what went wrong, you're going to see a lot of localism. And some of that's great. It will bring back jobs. It will force investment from companies that have relied on cheap solutions from different parts of the world. So I think it's going in two different directions. Workforce, no. Supplies, yes.
Interesting that, because if you think of the footprint of some of our bigger trusts and their buying power and the impact on the local health economy, I just won't believe that it's not possible for them to buy their masks and gowns, even if the trusts themselves have to invest in the companies and become partners in delivering these things. So you find somewhere other that can sort of do it, give them the money, invest in the kit and caboodle, and make the stuff locally.
Yeah.
I don't believe it's not possible.
Roy, I know we've got to close, but I remember my own personal fear when we were trying to project the COVID wave in the UK and then juxtaposing that with the number of ventilators. And I don't think any human being, and certainly those that have worked in the health service, should be put under that degree of anxiety ever again. Waiting for a flight from Turkey or a boat from China to think about the ventilators that this country needs, that should never happen again. And if that means we actually stimulate our local economies as jobs are lost to try and preserve and increase better value and better paid jobs, then this will be one good thing that's come out of this awful pandemic.
Well, amen to that, Mark. Thank you very much.
Mark, it's a great note to end on. I haven't realised where the time's gone. It's just flown by. Thank you so much, Mark. We're going to see if we can tempt you to write a piece for us on your 10 points, because I know our readers and the IHM will be interested in that. So if you've got the time to do that, we'd be really grateful. We can like to expand those. Perhaps we can have another conversation when we get further down the line. Whenever I see Mark, I always end up saying, well, Mark, see you sometime and safe travels. We don't have to do that now, but I can say, Mark, thank you very much and keep safe. We're really grateful to you.
We'll meet again.
Thank you, Vera.
Thank you, everybody. Those that are listening, just before we go, do tune in if you're a member of the IHM exclusive health chat opportunity with the great Peter Carter on Wednesday this week, giving us the benefit of his huge knowledge on resilience. So if you'd like to register for that, do please go on the IHM website or follow the social media, book your place now. It's already nearing sold out. Thank you very much, both of you. See you soon, and thank you for watching, all those at home. Bye-bye.